Welcome to The Explainer. Today, we are diving into a really perplexing and painful condition called complex regional pain syndrome, or CRPS. It's a condition that truly turns our whole understanding of pain on its head, and we're going to break down why. So let's just start with a question that gets right to the heart of it. Is it possible for something as small as a sprained ankle, or even just getting your blood drawn, to spiral into years of disabling, truly excruciating pain? For someone with CRPS, the answer is a heartbreaking yes. And that paradox is the mystery we're unpacking today. So, what is CRPS officially? At its core, it's a chronic thing, a malfunction of the nervous system. But the key phrase, the one you really need to remember, is right there: wildly out of proportion. We're not talking about a nagging ache that hangs around too long. We're talking about the body's entire pain system going haywire, creating a level of agony that's become completely disconnected from whatever first set it off. And that brings us to our first section, because understanding this whole out of proportion idea is absolutely key to getting why CRPS is so bizarre and, frankly, so difficult for everyone involved. This analogy just nails it. Think about it. A little puff of smoke from some burnt toast should, at most, make your fire alarm chirp for a second. But in the world of CRPS, that tiny little trigger sets off this deafening alarm that doesn't just stay on, it seems to get louder and louder, as if the entire house is burning to the ground, when there's no fire there at all. So, how in the world did medicine even start to wrap its head around a condition this strange? Well, it was not easy. The road to a clear diagnosis was long and confusing, a real medical detective story that took more than 100 years to unfold. It all starts way back in 1872 with something called causalgia, which was just a name for the terrible burning pain a doctor kept seeing in injured soldiers. Then you fast forward to 1946. The name changes to RSD, and that's a big deal because scientists were starting to think the sympathetic nervous system was involved. But, doctors everywhere were using different rules, different names. It was a mess. So in 1994, they finally got together and said, okay, let's call it CRPS and use one set of rules. And that felt like a breakthrough. But there was a huge problem. And that flaw was, well, it was a doozy. Having one name was great, but the rules they came up with to diagnose it, they were shaky. They were based more on what doctors thought than what the actual data showed. And that led to some serious problems for patients. 36%. This is the number that just blows the whole thing up. This was the specificity of those old rules. So what does that mean in plain English? It means the test was wrong almost 2/3 of the time. It couldn't reliably tell the difference between CRPS and other pain conditions. People were getting misdiagnosed left and right. The medical community knew they needed something way, way better. And that's when we get to the Budapest breakthrough. This wasn't just another committee meeting. This was a total game changer, because for the first time, researchers actually looked at hard data from real patients to see how all the signs and symptoms really fit together. It was all about creating a diagnosis based on evidence, not opinion. And this table shows you their brilliant new approach. They found that CRPS shows up across 4 main categories. But here's the genius part. They made a crucial distinction between what a patient reports, the symptoms, and what a doctor can actually see and measure, the signs. Just that simple shift, demanding objective evidence, changed everything. So here's how the new rule works. First, the pain still has to be way out of proportion. Then, the patient has to report symptoms in at least 3 of those 4 categories. But, and this is the kicker, the doctor has to personally observe a sign in at least 2 of them. After you rule out everything else, what happens? That terrible 36% specificity jumps to a much more reliable 68%. Finally, doctors had a tool they could actually trust. Okay, so now that we've got a solid way to diagnose it, let's look at the 2 different paths that can lead someone to a CRPS diagnosis. Because while the fight is the same, the story of how it starts can be a little different. The difference is actually pretty straightforward. Type 1 is the one you see most of the time, about 90% of all cases. It starts after an injury, sure, but there's no proof that a major nerve was damaged. That's the one that used to be called RSD. Then there's type 2. That's when you know for sure there was a direct hit to a specific nerve, just like that causalia they saw in soldiers. But honestly, here's the most important thing to know about these 2 types. Even though one starts with a known nerve injury and one doesn't, for the person going through it, the signs, the symptoms, the suffering, and for the doctors trying to treat it, the approach is pretty much identical. It's like the initial trigger just lights the fuse to the same very complicated fire. So we've talked a lot about the clinical side of things, the history, the rules for diagnosis, but now let's get to the human side. What's it actually like to live with that fire alarm blaring day in and day out?
First, who gets this? The numbers are pretty stark. It affects women 3 to 4 times more often than it affects men. And while it can show up at any age, it most often appears for the first time when people are between 50 and 70 years old.
And check this out. How common is it after a regular old injury? One major study followed people after a simple fracture, and the result is kind of staggering. Almost half of them, 48.5%, developed symptoms that met the criteria for CRPS. It's just a shocking reminder of how a routine injury can go so horribly wrong. And this is so much more than a pain condition. It creates this devastating ripple effect across the body. Your motor system gets hit, causing weakness or tremors. Your skin can literally change, becoming thin and shiny. The body's own thermostat breaks, causing weird swelling and sweating. The pain can even spread, sometimes showing up as a mirror image on the other side of your body. So it is absolutely no surprise that living with this constant multi-system assault leads to really high rates of depression, anxiety, and even PTSD.
And all of this leaves us with one final profound question. Usually, we think of pain as a symptom, a sign that something else is broken. But what happens when the pain signaling system itself is what's broken? When the pain is the disease? It forces us to rethink everything we know about injury, about recovery, and about what it really means to heal.